Welcome to this Step 3 review on seizure management, brought to you by Roadmap to Residency. Seizure questions show up constantly, and they almost never ask you to recite a mechanism. They ask what a working physician does next for the patient in front of them. Today, we are not reteaching epilepsy. We are showing you how the stems are built and how to attack them. The first seizure workup, choosing a medication, the breakthrough seizure, and the driving conversation. Keep your question bank and a trusted review resource open alongside this video. Let us get started. Here is our game plan. First, the first seizure workup, where the exam tests whether you can resist ordering everything at once. Second, medication selection, where the answer is driven by a detail hiding in the stem. Third, breakthrough seizures, where the reflex to increase the dose is usually the trap. And fourth, driving restrictions, which test judgment rather than recall. Along the way, we will walk through practice questions and explain why every answer choice is right or wrong. This video assumes baseline knowledge from your review resources. We are here to sharpen how you take the test. Our first strategy is to ask whether this was even a seizure. The witness account is your diagnostic test. Look for the aura, the stiffening and jerking, the tongue bite, the loss of bladder control, and above all, the confused sleepy period afterward. That postictal confusion separates a true seizure from a simple faint, where the patient comes right back within seconds. When a stem spends 3 sentences on what a bystander saw, the diagnosis is clinical, and the choice offering another test to confirm the event is a distractor. Next, hunt for a provoking cause. Low blood sugar, low sodium, alcohol withdrawal, sleep deprivation, cocaine, and new medications all provoke seizures. If you find a reversible cause, fix that cause, and starting a long-term medication becomes wrong. This fork decides an enormous share of these questions, so look for it first. Strategy 2 is the order of the workup, because this exam rewards sequence, not enthusiasm. For an adult with a first seizure who has returned to baseline, the immediate workup is cheap and fast. A fingerstick glucose at the bedside, a basic metabolic panel to catch low sodium and low calcium, a toxicology screen, and a pregnancy test where it applies. Neuroimaging of the head is standard in an adult with a first unprovoked seizure because you are looking for a mass, a bleed, or an old stroke. Now, the electroencephalogram. It matters because it classifies the seizure type and predicts recurrence. But in a stable patient who is back to normal, it is an outpatient study, not an emergency one. When a choice demands an urgent brainwave recording on a patient who is awake and conversational, it is doing too much too soon. Order the study, but order it as follow-up. That distinction is where points are won. Now, choosing a medication. The core idea, read the patient, not the drug. The stem always hands you the deciding detail. A woman of childbearing age steers you away from Valproate because of the harm it causes to a developing fetus. An older adult on 5 other medications steers you toward an agent with fewer interactions. Those details are the answer key. Second, match the drug to the seizure type. Narrow-spectrum agents can make certain generalized types worse, so when a stem describes staring spells or jerks of the arms in the morning, it is begging you to classify the seizure before you pick. Third, the one people miss. A first seizure is not always treated. A single unprovoked seizure, with a normal examination, normal imaging, and a normal recording often needs no medication. You favor treatment when recurrence risk is high. Do not reflexively start a drug, because the word seizure appeared. Let us do a question together. A 22-year-old man is brought to the emergency department after his roommate saw him stiffen, jerk all 4 limbs for about 1 minute, and then lie confused for 15 minutes. He had been awake for 2 days studying, and he drank heavily last night. He is now awake, alert, and oriented, with a normal neurologic examination. His glucose, electrolytes, toxicology screen, and neuroimaging are all normal. Which of the following is the most appropriate next step in management? Read through the 4 choices. Notice what the stem gave you and what it took away. Let us break this down. The witness description confirms a real seizure, so do not waste energy questioning that. But look at what the stem planted in plain sight: 2 days without sleep and heavy drinking. Those are 2 classic provoking causes handed to you for free. Then look at what came back: glucose, electrolytes, toxicology, imaging, and examination all normal, and the patient at his baseline. A normal workup is not a boring detail. It is the exam, removing every reason to start a medication. So, a provoked seizure with a reversible trigger and a normal workup is managed by removing the trigger, counseling him on sleep and alcohol, with an outpatient recording to gauge recurrence risk, is appropriate and cost-effective. That is choice C. Now the wrong answers. Choice A treats a provoked seizure as though it were epilepsy, and it is not. Choice B, admitting a well-oriented man for continuous monitoring is expensive and adds nothing when he is already at baseline. That is the overkill trap. Choice D is wrong twice over. It starts a medication he does not need, and Valproate is a poor first choice in a young patient. The correct answer is counseling with an outpatient brainwave recording. Here is our second question, and this one is about picking a drug. A 19-year-old woman is evaluated after 2 witnessed generalized seizures in 3 months. For the past year, she has had jerking of both arms in the morning, often causing her to drop her toothbrush. Neuroimaging is normal, and her brainwave recording shows a generalized pattern. She is sexually active and uses condoms only. Which of the following is the most appropriate initial therapy? Look through the 4 choices. Notice how much specific detail the STEM gave you about who this patient is. That is not decoration. 2 details decide this entire question, and both sit in the STEM. The first is the morning jerking of both arms with a generalized pattern on her recording. That tells you this is a generalized epilepsy, which rules out narrow-spectrum agents. The second is who she is, a 19-year-old woman who is sexually active without reliable contraception. Together, those 2 facts eliminate 3 of the 4 choices before you weigh any drug. That is the whole game. So why Lamotrigine? It covers generalized seizures and is a reasonable choice in a woman who could become pregnant, and folic acid is standard for any patient of childbearing potential on these medications. Now the wrong answers. Choice A, Valproate, is genuinely effective for this seizure type, which is exactly what makes it the trap, but it causes serious harm to a developing fetus. Effective is not the same as appropriate. Choice B, carbamazepine, is narrow spectrum, fine for focal seizures, but it can make these morning jerks worse. Choice D ignores 2 seizures in 3 months and a year of symptoms. This is established epilepsy and it needs treatment. The correct answer is Lamotrigine with folic acid supplementation. Now, breakthrough seizures, meaning a patient who was well controlled and suddenly seizes again. The exam has 1 lesson. Find the reason before you touch the dose. Adherence is your first question, every time. Missed doses are far and away the most common cause, and the STEM usually leaves a clue, such as a patient who ran out of pills, lost insurance, or has been traveling. After adherence, look for new medications that interact: illness, sleep loss, and alcohol. A drug level is a cheap test that answers a crucial question. Is the patient actually taking this? Here is the trap. The reflex answer is to increase the dose, and it is usually wrong. That treats the wrong problem, and adding a second drug on top of an unaddressed cause is worse. Fix the reason first. Raise the dose or change agents only when the patient is adherent, the level is therapeutic, and there is no reversible trigger to blame. Here is our third question. A breakthrough seizure. A 34-year-old man with focal epilepsy, well controlled on carbamazepine for 3 years, has a witnessed generalized seizure at work. He returned to baseline within 30 minutes. He mentions that he changed jobs 2 months ago, lost his prescription coverage, and has been taking his medication every other day to stretch the supply. His examination is normal, and his neuroimaging is unchanged. Which of the following is the most appropriate next step in management? Look through the 4 choices. The STEM practically handed you the answer in 1 sentence. There is a confession sitting in the middle of this STEM. The patient tells you outright that he lost his prescription coverage and has been taking his medication every other day for 2 months. That is your cause. This is a social and financial barrier, not a pharmacologic failure. Checking a level confirms it, and it will come back low. Addressing the cost barrier, whether through a generic, a patient assistance program, or a social work referral, fixes the actual problem. That is choice C. Now the key distinction. Choice A, increasing the dose of a drug he is not reliably taking, is dangerous. The moment he can afford his prescription and takes it as directed, he becomes toxic on a dose raised for the wrong reason. Choice B layers a second medication and a second set of side effects onto a problem that was never about the drug. Choice D, admitting a man who returned to baseline within 30 minutes with an unchanged scan, is expensive and changes nothing. Notice the pattern. Every distractor escalates therapy while ignoring the stated reason. When a STEM tells you why something happened, the answer addresses that why. The correct answer is to check a level and address the cost barrier. Here is a topic people rush past and get wrong: driving restrictions. The exam loves it because it tests judgment rather than recall. First, counsel directly and document. The patient must not drive until seizure-free for the period their state requires, and you must say so plainly and write it in the chart. Any choice that avoids the conversation or hands responsibility to a spouse is wrong. Safety counseling also covers swimming alone, working at heights, and showers rather than baths. Second, know the reporting fork. Requirements vary by state. Some require the physician to report, and others place that duty on the patient. The safe answer counsels the patient, documents it, and follows the local requirement, rather than ignoring the issue or breaking confidentiality without cause. Your practical pearl. When a STEM offers a choice that simply says, counsel the patient not to drive and document it, that is very often correct, even when a flashier medical choice sits right next to it. Do not skip the boring answer. That wraps up our review of seizure management for Step 3. Let us lock in the core ideas. For a first seizure, characterize the event from the witness account, then hunt for a provoking cause. Run the cheap workup first, and remember the brainwave recording is an outpatient study in a stable patient. For medication selection, read the patient, not the drug. For a breakthrough seizure, find the reason before you touch the dose and start with adherence. And for driving, counsel plainly, document it, and follow the local requirement. That boring answer is usually the right one. Make this automatic by drilling questions in your question bank under timed conditions, using the epilepsy chapter of a trusted review resource, and read every explanation, even on the ones you got right. Visit roadmaptoresidency.com for expert tutors and residency advisors who can help you build a personalized study plan. If this video helped, please like and subscribe so you do not miss our next board review session. Good luck on your exam, and we will see you in the next video.